my pleasure to introduce Erin. Erin Judge is a registered dietitian, nutritionist, certified personal trainer, and founder of Gutivate, a virtual nutrition counseling practice for digestive disorders and gastrointestinal conditions. Erin's expertise is in providing medical nutrition therapy for functional gut disorders with a patient-centered focus. She is proud of her work in education and advocacy for the IBS patient community through social media, as well as her work in providing resources for dietitians in the GI field. And with that, Erin, I'll pass it to you.
Thank you so much for having me. I have some disclosures on this page that is somewhat notable, I guess, for this conversation, because we are going to talk about some products in my own practice. So I wanted to make sure to disclose those properly. And before we jump into the supplement conversation, I just pulled this out of a great review from 2024 by Kevin Whelan and his colleagues. If you have not read this yet, it's a great review, especially for dietitians. Nothing brand new, but still really helpful to review. But when we talk about the role of us as dietitians, diet therapies for IBS are pretty strong, and dietary interventions for IBS, GI symptoms, are strong. That is our first line. Supplements are usually not first line therapy. A lot of our conversation today is so supplement heavy, and I think we can look at it from a lens of we're only using supplements. So I just wanted to set us up here because we're not going to get into diet very much at all. I want to focus on the supplements. But remember, whole diet interventions are our first line. They are necessary. They are the hierarchy of what we do. Supplements are there to complement that work and complement the treatment for patients overall and with other colleagues. So just want to set the stage with that, just because I think it can get lost, and I want to make sure we're all on the same page. Now, we have a lot of slides today, and I'm not going to talk about everything on the slides. A lot of them are going to be research breakdowns. So I have that for you to review later, for you to kind of read as we talk through more practical application. But I do want to cover as many supplements as possible that have some evidence, and then some that are also commonly used in practice. And I thought it could be helpful with our IBS specific population to kind of break down a few symptoms or kind of maybe buckets of strategies that we may use. So I'm breaking this down into pain, bloating and gas, kind of those post-meal symptoms, and bowel movement. So you'll see kind of a breakdown of different supplements in these different areas, just to help keep us a bit more organized. So one of the most utilized supplements in this space are peppermint oil capsules. This has been around for a bit longer. I feel like this is something that's not necessarily new to many of us. But if you're not familiar, the L-menthol that's in peppermint oil, and this is important to bring up because you're going to see peppermint leaf as well, but specifically to peppermint oil, we have L-menthol, which helps act as an antispasmodic. And so when we think about pain, if we can reduce some of that, if there's already hypersensitivity with IBS, if we reduce some of that sensation of the muscle itself by calming those muscles down, that can help then reduce the pain that people feel. As a side effect too, you may experience less bloating, gas buildup, maybe less trapped gas. Sometimes motility can be improved, where we may have less cramping, less diarrhea, sometimes improved constipation. But pain really is something that has been studied in these capsules and with peppermint oil, which is very special when it comes to IBS, because pain is a big marker of IBS and something that can be tricky to target with other treatment interventions. So when we look at the different options out there, the enteric coated capsules are designed to release this oil in the small intestine rather than in the stomach, if you're just like dropping oil on your tongue or eating it or somehow. And that allows the peppermint oil to act in the small intestine, maybe even in the colon, which is where we're going to see the most benefit in terms of that pain, that hypersensitivity. With the small intestine, that's where we may see some improvement post-meal, where if we have increased sensations right after a meal, again, that trapped gas, the bloating, anything like that, these peppermint oil capsules can be really helpful. There is decent research, and I put a few studies here, some kind of older studies, but we also have this 2021 double-blind trial. And we do see some benefit in IBS symptoms. Heartburn can be a mild side effect. And so this is something that we'll kind of talk about in terms of dosing. This one from 2020 was interesting because it did find no significant reductions in symptoms, but for both. But what it did see is that if you tested small intestine released versus ileocolonic release capsules. So they looked at the different release areas of the gut. They found that there was a decrease in pain, discomfort, and severity more with the small intestine release capsules than the ileocolonic, which is interesting, especially when we look at IBS. You would think ileocolonic would be better, but that just kind of goes back to prove that the capsules that are on the market right now can be really helpful. This is the newest study I found, and this is for a specific peppermint oil capsule called Zio Y60. I have no idea the brand of this. This was out of Japan, and I could not find exactly where you could have purchased this or where this has come from. So it may only be available in Japan, I'm not sure, but they saw significant reduction in symptoms with IBS patients. So maybe this formulation is even better, but who knows? We don't know what it is, but interesting to see there is some decent data, and the safety is pretty high. So again, the biggest safety risk would be an increase in heartburn. And so that would be personalized with a patient. That's where you can change your dosing. So the enteric-coated small intestinal release, that alone will help reduce the potential for heartburn. Right now, the best option I've found is IB Guard. For this, patients will use lots of different ones on the market. I know that a lot of my patients will grab towards other ones. I always say test what's available, maybe because of price or preference and other ingredients. But if you're not seeing results that you're expecting, kind of going for those enteric coated, making sure that it is enteric coated. And again, IB Guard is one that has been studied to show that small intestine release. And then I usually dose this at 1 to 2 capsules, 15 to 30 minutes before meals. I find that if a patient's having a lot of heartburn, that sometimes dosing it after the meal is better. Or with the meal, like it doesn't have to be perfectly before, like that's just really trying to line up the release of the peppermint oil kind of as digestion is happening, but you can personalize this with patients. This can also be done kind of retroactively. So if someone's having a lot of cramping and pain, you can utilize peppermint oil in those cases. So there's a lot of ways that we can work with it. We'll come back to that. What about a combination? So STW5, which is also Iberogas. That's the brand name. This is a blend of bitter candy tuft, peppermint, chamomile, licorice balm, or lemon balm, and caraway. And this is, yes, using the peppermint oil to help relax muscle, but utilizing some of these other herbs for other potential digestive benefit. So possibly looking at stomach acidity regularity, and that may help with dyspepsia and kind of upper GI symptoms, relaxing those muscles, improving GI motility, maybe through the like the chamomile, the licorice, protecting the mucous membrane of the gut. That's something that they lean into, and then some anti-inflammatory properties from these different ingredients. So there is some research showing promising results in symptoms in both IBS and functional dyspepsia. These exact mechanisms aren't necessarily proven. So whether these ingredients are doing all of these things, we don't really know. But those kind of the thought of like why these herbs were chosen. Now with Iberogas specifically and STW5, this used to be feared for liver injury due to some reported events. So it kind of left the scene for a while and then now has come back. And I will admit, I don't use this very often for that reason. So I was looking into this a little bit more because I have colleagues that use this more frequently, even than just peppermint oil capsules, and find a lot of benefit from it. And what happened in 2023 is really important. So they used to include Angelia root milk thistle and a celandine, greater celandine, which is thought to be maybe that ingredient that was linked the most with liver injury. So it used to have more herbs included, but now what you're going to get on the market from 2023 on is this blend that is here at the top. So some of the older research is using the older blend, then newer research will be using the newer blend. So I did pull out 2 studies you can review that are both 2020, post that 2023. And what we see are decreases in pain. So with this one, they're looking at tolerance of gas. So gas happened for both groups, but with utilizing the herbal blend, there was better tolerance. So less kind of discomfort, less pain, less sensation of that gas, even if the gas was still present, which is important when we look at hypersensitivity with IBS. And then looking at reflux specifically, they found in those with functional dyspepsia, they found that there were a benefit in symptoms, so fewer reflux events, And they thought it was due to kind of decreased esophageal hypersensitivity because of these herbs. So some theories, again, the research is decent. I wouldn't say it's amazing yet. But if we pull out that, okay, peppermint oil research in combination with maybe some of these other herbs added, some patients may benefit from more of a combo approach. This is usually going to be found in a liquid form. And so the dose is 20 drops, recommended up to 3 times a day before meals. The bottle must be shaken but it can be mixed with a small amount of liquid. So you don't have to just do the drops on your tongue. I will say when we think about liver risk and we think about dosing properly, I don't like droppers because I find that dosing 20 drops is a little hard to do. And you could easily go from 20 to 40 without really thinking about it. And we do still want to be concerned about liver risk, right? Because there still were some events noted in the past and with any supplement. So that's tricky. However, there is a soft gel form now available in the US. It's not the form that was studied in the studies that I could really identify. But that is really interesting as an option that I was actually unaware of until digging back into it. So one that could be considered. There's also another peppermint combo. This brand name is Atrantil. And so this one has Quebrancho Colorado, which is in place to try to reduce gas, horse chestnut as an antimicrobial, peppermint leaf to soothe gut muscles. So they use the leaf instead of the oil, which is interesting. This is marketed heavily in the SIBO microbial overgrowth space because they're seeing that their combo can reduce hydrogen levels. And then they also have this kind of antimicrobial property. So their thought is by reducing hydrogen and possibly adding an antimicrobial property to their supplement, they might be able to reduce some of the pathogens. So possibly the methane producers and the hydrogen sulfide producers. So taking away the hydrogen and possibly having an antimicrobial effect, which would then improve bloating and the potential for overgrowth. They also believe to support gut motility. So you're going to see this recommended a lot in the constipation kind of slow motility space. There was a decent pilot study in 2016 looking at IBS-C patients with pretty significant results. And then I found a larger study. I remember this being talked about in like 2020, and I found the kind of the abstract that was presenting the study for people to sign up, kind of presenting it for approval. And it ended in 2022. I could not find the results to this study. If you can, please share them. Maybe Jocelyn can send them on because I did not find them, which makes me curious of did we see results or not? And I think that's really important to know because this pilot study was so small. I will say in practice, I find that some people really do like this product. I've used it myself. I've had patients who really enjoy it and use it and have seen benefit from it while they use it. I haven't necessarily seen benefit like after use as like a fix, if you will. So it's not like a SIBO treatment, but some people do like this combo. Now, safety in terms of like liver over time, some of that is unknown with some of these other herbals. So this is not meant to be an everyday for the rest of your life treatment. And it is typically dosed at 1 to 2 capsules 3 times a day. Some people will even dose higher than that. And again, it's peppermint leaf, not peppermint oil. So would this be first line? For me, no, but something that is out there that you'll see patients use. And even a lot of doctors recommend that and have been involved in some of that research, which again, I hope we can see. So when I'm thinking about pain specifically and thinking about some of these supplements, how do I practice? And the chat is open. I'll let Jocelyn monitor that some, but if you have ways that you practice and utilize some of these supplements, like include your reasoning, because this is simply my approach and I'm not the only dietitian in this space. And there's a lot of options here, right? So if I'm looking at a patient with IBS and they have pain present with meals, I put low-fi diet in here because obviously I'm doing a diet intervention, usually first, but maybe even before a diet intervention, if that's not something that we can do yet, or patients already gotten through diet interventions, or they're already really stressed about symptoms, then I may utilize IB Guard with meals, 1 to 2 capsules, usually with the meals that the pain is present after. So I'm not quick to say, take 2 IB Guard with every meal. I want to know, when is pain present? If pain is usually present afternoon and evening, then I may say, okay, let's start with one IB guard before lunch, one before dinner, and then I may adjust that dosing based on their results. And then possibly remove the IB guard when we have other interventions in place, like playing with it a little bit and personalizing it with the patient. That's a great approach. This is really nice for patients who, again, maybe can't eliminate food from their diet, or there's a lot of stuff going on, even maybe a placebo effect. Or again, this is a safe option. I like to go with simply the peppermint oil capsules before a combo of different herbs, because there's extra safety here. And so if a patient is also wanting a placebo effect to help with pain, because we know gut-brain access is involved there, this can be really helpful. Now, if pain is present with bowel movements, I do utilize peppermint oil for this as well. So especially with my diarrhea patients, if we have a lot of cramping in the morning, I might actually dose IB guard or dose peppermint oil capsules upon waking. And with that first meal where that cramping, that urgency is more severe. The same is true in the evening. If a patient wakes up with a lot of cramping, maybe we dose it in the evening to calm muscles overnight. There's a lot of options there that you can take. Again, working with the patient, utilizing the mechanisms we have, again, the best evidence that we have in practice in the most safe way possible, and then monitoring, follow up, reduce supplement use as much as possible within time. The other herbals I might use if some of these are not working, but we'll get into some other supplements I may use more frequently. So when we're thinking about bloating and gas, pain is involved in all of this, right? So the pain part was a little bit short. But one of the first things that we may be thinking about are enzymes. And enzymes, I mean, you guys are here for this workshop right now from an enzyme. So why are we using enzymes? What is the evidence for them? So there's a few that are commonly used. Alpha galactosidase is very often used, and this breaks down certain types of oligosaccharides, especially those found in beans, cruciferous vegetables, some FODMAP-rich foods, like your galacto-oligosaccharides. Now, has this been studied? I'm looking at IBS specifically. So there are some studies of whether or not alpha galactosidase, we'll talk about lactase, and some of these other supplements work to actually be an enzyme for what they're breaking down. But what about for IBS, right? Because that's what we're in this room for. So there was a study done looking specifically at just alpha galactosidase added to carb-rich meals and looking at symptoms. And they didn't see any improvement over a placebo for gas or symptom reduction, but some subjective improvements about bloating and pain kind of the next day. So maybe a benefit. Now, the meals that they tested did include other FODMAPs, and we're going to talk about why it's important, because this is just one enzyme for one group. So not really the best study to look at, but Beano is a common brand. Bean Assist is a brand. These have been used for a long period of time. We know that they can be beneficial, especially for things like beans, in patients who are reacting to those foods. I would say just alpha galactosidase alone, I may utilize if beans are the only problem, or it's a non-IBS patient. Again, we're trying to increase their fiber, and that's something that we're identifying, not necessarily a broader FODMAP intolerance. Now, what about beta galactosidase or lactase? So this breaks down our lactose, the sugar in milk and dairy. Those of you in the room, this is not new. There is a very old and weak study on IBS patients looking at lactase supplementation in patients who consumed milk, and they did not see an improvement of symptoms overall, but they did find that more results were present for those who were lactose maldigesters, which is very obvious. If a patient has lactose intolerance, then adding lactase in to help break down that excess lactose that their body might not be breaking down can be beneficial, right? And so we know that to be true. And lactose intolerance, as well as lactase deficiency, are commonly present in IBS populations, and that will worsen symptoms because there's maldigestion involved. So this can be helpful. Now, when we look at some of the research on supplementation, there's some benefit to supplementation for lactose intolerance, but truly, dietary intervention of overall reduction in lactose intake is actually more effective in the research compared to supplementation, specifically in lactose intolerance. And most people tolerate up to about 12 grams of lactose, which is a cup of milk. I would say the low FODMAP consideration is less than a gram. So it gets a little funky in terms of FODMAPs versus lactose intolerance. And again, that's really leaning back to the dietitian to help patients understand where they actually fit within a lactose intolerance spectrum. Are they reacting to lactose? Testing lactose amounts, understanding where their tolerance lies, and then utilizing the supplement in addition to that so that there's a lot more confidence with that supplementation. You can also make it easy for a patient, add it in, it's safe to utilize. Again, something like a Lactaid would be lactose only. And then you would dose it kind of above their tolerance if you can, or just sort of play with the dosing on the cap. There's not a lot of good like dosing guidelines. What I find helpful is knowing, okay, where's the tolerance amount? Testing around an 8-ounce glass of milk can be helpful. Like, where do we fit there? And then whenever you're over that amount, maybe one dose per every 5 to 10 grams above that. But that's very much this is just what I find can be helpful if you need some sort of guidance to follow. With looking at enzyme dosing, they should always be dosed with the food, typically at the first bite. And so you would either, for lactase, sometimes you can add it to the product, or you would be like taking, usually there's chewables that people utilize the most, like the Lactaid kind of instant rapid release. Take the chewable, eat the ice cream. There you go. What about other brush border enzymes? So lactase is what we call a brush border enzyme, meaning it's released on the brush border of the small intestine. And this is really important because newer research is showing that in some IBS patients, we're seeing deficiencies in disaccharidase activity, these brush border enzymes like sucrase isomaltase, which breaks down sugar in some starches, maltase glucoamylase, which breaks down starches, lactose, and then trehalase, some other ones as well. But this sucrase isomaltase kind of maltase piece has shown up a lot more in newer research. And there's an estimate that around 1 in 10 IBSD patients may actually have sucrase isomaltase deficiency. Now, this can be kind of tricky because this deficiency can also be secondary to damage done to the brush border and the lining of the small intestine. So in those with celiac disease, maybe in some cases of SIBO, where there's been inflammation or some sort of infection, maybe in some cases of IBD, right? If we have inflammation or damage, then we may have a decrease in some of this enzyme production, and it might come back and improve, it may not. There's also congenital forms of these where this is going to be present from childhood, but these are things that we can actually test for. We can test for lactase deficiency, we can test for sucrase isomaltase deficiency, and it's something that we want to keep on our radar because these patients are going to react to things that maybe aren't as obvious. Lactose is obvious. Sugars and starches may get missed, especially if you're looking for FODMAPs, you're looking for lactose, and you're looking for some of the more IBS specific things in the diet. So something to be mindful about. Now, in terms of supplementation, there's not a lot of good research around this kind of supplementation in IBS patients alone. There is a sucrase isomaltase enzyme that is prescription only currently through Sucrade. There's some other ones on the market. I have not used those. I think the one's called like Starch Away. If you have used those in practice, like please put them in the chat, because Sucrade, which is that prescription level enzyme, works extremely well for sucrase isomaltase, and you would dose it, like test sucrose first, then starches. So sugar, then starch, dose accordingly. But it can be very expensive for a patient, and there's a lot of controversies around testing to get even approval for that prescription coverage through insurance. And so there are some on the market that are meant to target this, but not quite to the degree that Sucrade does. That might be helpful. Dietary intervention can also make a huge difference. So kind of a bit of a sidebar because this wouldn't necessarily be IBS specifically, but definitely something I wanted to mention. And you may see more of these enzyme blends that may have some of like something looking at sucrose and maltose in addition to kind of our FODMAPs. And this may be the reason why that's coming up. And there's a great article I linked here at the bottom that I think is really helpful if you're kind of new to that space and you have no idea what I'm talking about, the sucrase isomaltase. And then what about looking at fructans or inulins? So this is kind of a newer piece building off of like alpha-galactosidase and lactase. Can we target more FODMAPs? beyond just our beans and our dairy. So with fructans, there are many different types of fructans. So I threw inulinase in here because inulin is one type of fructan. So there are some inulinases on the market as well. Fructan hydrolase is a little bit broader in that it targets multiple types of fructans, not just inulin. So it might be more helpful in the context of food in a diet and FODMAPs overall, kind of if you're trying to do a broad sweep of many different FODMAP groups. But how this works is it breaks apart the fructan molecule. Our bodies don't produce fructan hydrolase necessarily. Microbes do. So you break apart the fructan molecule to pull out the fructose, allows for absorption, reduces that fructan delivery in the colon, reducing symptoms, especially in those with IBS, where increased amounts of fructan in the colon lead to excess fermentation, more of that osmotic activity, right? More, and because of that hypersensitivity, they're going to have symptoms. So if we can target some of that and try to reduce that fructan activity in the colon, not just from food elimination, but from enzyme supplementation, can we see a benefit? This blend, which is FODzyme, that has lactase, alpha-galactosidase mixed with fructan hydrolase, does have a little bit of evidence that, one, it does actually break down high FODMAP fructans, which is important to reduce symptoms. And then they do have a symptom-specific reduction from a SHIME GI model. So no human trials yet. I'm going to say a big yet. Jocelyn can keep us updated on that. But there's some evidence backing it up. I have not seen even this level of evidence in some of the other ones on the market. I personally don't use those as often, but there are some others on the market that are like different inulinases and things like that. So they do exist. This one I think is unique, but if you have found one that you think is really helpful for your patients or has some evidence that maybe I haven't seen, let me know. And then I've linked these studies down here if you're interested in looking at, okay, why make this work? And then there's also xylose isomerase. So looking at the fructose of it all. And this is a FODMAP as well. So again, when we looked at that other blend, we have alpha-galactosidase, mostly that GOS group, our fructan hydrolase for our fructan group. We have lactase for our lactose group. So what about our polyols and then our fructose? Xylose isomerase has been used. It's not naturally produced in the body. It's produced by other things. But it does help break down fructose and may be helpful in fructose intolerance. This hasn't been studied in IBS, but in those with fructose intolerance, supplementation was shown to reduce hydrogen in symptoms. I would say I see very mixed. I don't see a lot of fructose intolerance in my practice, so I don't have a huge population I've used this on, but I've seen a mixed results from it. And again, I want to hear your thoughts if you've used this in your practice. It's safe. Enzymes are likely very safe, but does it actually work? It can be worth a try before you eliminate a large amount of foods, but it may be more helpful in those who are very much fructose malabsorbers than just FODMAP malabsorbers. And if we look at that newer FODMAP research, right, where we might get into more of like a stepwise approach, fructose isn't necessarily one of the highest groups that tends to trigger the most symptoms, like our fructans, our GOS, even our mannitol, and then again, our lactose and our lactose intolerance patients. So is there room for a specific subset of patients here, sort of like that sucrase isomaltase group? I think so. That's a little bit aside, but that's where this supplementation might be used. Not something I use in practice, but it does exist. And then what about pancreatic enzymes? Prescription level enzyme therapy. So these are going to be your enzymes that break down kind of all of your molecules, right? So your amylases for your carbohydrates, your proteases for your proteins, your lipases for your fats. There is an older review of alternative therapies that noted pancreatic enzyme therapy being widely used, but there's really not a lot of proven clinical efficacy in IBS, even except those who have that coexisting exocrine pancreatic insufficiency, which is what this is used for the most. Now, some IBS-D patients may have clinically relevant pancreatic insufficiency. So they may get tested and have what could be diagnosed as pancreatic insufficiency, and you may see that enzyme supplementation improves symptoms. There is a lot of debate currently on whether or not just doing like the stool testing, looking at pancreatic elastase, if that's actually showing true pancreatic insufficiency or not. This is very highly debated. And again, we could debate this all day if you wanted to. We're not going to, but that's something just to consider. Now, as dietitians, we are not recommending pancreatic enzymes. The over-the-counter enzymes are not cutting it at this degree, right? This would be something that we work with the doctor on, but some patients may be at that level where pancreatic enzymes are going to be beneficial. And so we want to work with the doctor to do the right testing and then trial the prescription level enzymes. I just want to take a note here that as the dietitian, you are involved in helping patients actually practically figure out the right doses. I've worked with a lot of patients who are on pancreatic enzymes with clinically relevant testing, and they're underdosing their enzymes and still having symptoms, which they're marking up as IBS. And they're doing all these other things that aren't necessary when increasing pancreatic enzymes may be the answer for them. I've also seen a lot of patients on pancreatic enzymes that are doing nothing, and they had some lab work, but like they don't really look like a exocrine pancreatic insufficiency patient. Enzymes aren't working. And again, that's where we go back to the drawing board with the doctor to figure out whether we change the dosing of the pancreatic enzymes or trial other therapies specific to IBS. That's a lot. So going from enzymes, what about herbs? So we've talked about some herbs with like pain, but what about for bloating and gas and just improved digestion, if you will? Ginger is a hot one. So ginger can help decrease the pressure on that lower esophageal sphincter, maybe help with intestinal cramping, and it can help prevent dyspepsia, flatulence, bloating, because it's thought to help stimulate some of that emptying and upper GI motility. Now, has this been studied? There is a 2015 study looking at ginger, and they did find a significant increase in GI motility in their intervention group. So not just in IBS, but looking at it more for upper GI motility. And so it did help with overall motility. There was a very old 1999 study and also a 2008 study looking at ginger and gastric emptying, and showed that there was a benefit to ginger supplementation with accelerated gastric emptying, likely due to this pressure on the lower esophageal sphincter, and that it helps with those antral contractions in the stomach in healthy individuals. So not in those with gastroparesis, not in those with IBS, but maybe there is a benefit on, again, more of that upper GI motility. And then a 2011 study found the same results in functional dyspepsia without changes in like the fundus dimension of the stomach, GI symptoms, or even peptides. So regardless of the symptoms themselves, like helped with those with stomach emptying and again, more upper GI motility. So what about in IBS? Because not only could ginger possibly help with that motility in the upper GI tract, if it's also having an anti-inflammatory effect, could it be beneficial in IBS where there might be an immune piece or low-grade inflammation, maybe that intestinal permeability, right? There's a lot of theories that go on around ginger and different herbs in IBS. So this study was done in 45 patients, and they did a gram of ginger a day, 2 grams of ginger a day, or a placebo for almost a month. And they actually found that ginger in both doses did not outperform placebo in just the symptom severity scores. They did see that 53% of participants reported adequate relief with their placebo, and similarly with ginger. So maybe just the placebo effect. It was well tolerated and does seem safe as long as we're using the right dose and the duration of trial for the supplement. So is it harmful? Not necessarily. Now, when I think about dose here, ginger is not just benign, like really high doses of ginger might impact the liver. And so we do have to be mindful about that, especially with like the supplement industry and regulation. We're not talking about that today, but for ginger supplementation, you'll find really high doses of ginger kind of in these random supplements all over the place. And what else is added to the product, like there's a lot there that also needs to be considered. And so we can be kind of overdosing people. They might be overdosing themselves on ginger. So that is something just to be mindful about. So while it might be safe to try, especially in those with functional dyspepsia, maybe upper GI motility type of symptoms. So increased fullness after meals, like burping and bloating right after meals or while someone is eating, like this might be supportive while you're utilizing other interventions, even for our maybe microbial overgrowth patients with slow motility, if we're trying to impact and get some of that kind of prokinetic effect where maybe prescriptions are not an option yet for a patient, or price or whatever it may be, there might be some value, but we have to make sure it's safe for the patient, monitoring labs prior to recommendation and with use, and then making sure we're mindful about the duration of use of this as an intervention, just because we don't have great data on that. Now, what about ginger mixed with other compounds? So this is a newer study that looked at ginger with menthol and limonene. And again, not a large group of people, but they studied IBS and IBS plus functional dyspepsia patients. They found that there was improved symptom scores compared to placebo when added to whatever their standard therapy was over 30 days. Now, it's not clear if there was a difference in IBS and functional dyspepsia outcomes. Like, the thought would be functional dyspepsia might benefit even more than IBS based on the mechanisms we have seen, or, we have a little bit of data to back up, but they didn't really pull that out specifically that I could find. But there was some benefit. And again, this is a newer study. So maybe ginger, again, with other herbals, with other products, might be helpful. And again, maybe it's just the menthol. So what am I doing in practice? Looking at bloating, gas production in patients. So first off, screening for malabsorption where we can. Now, this may be done through diet therapies and testing. So working with your medical team, if you have access to that, that can be helpful. You can do breath testing for sucrase isomaltase deficiency, lactase deficiency. You can also do proper screening for pancreatic enzyme insufficiency. So if you have that, prescription enzymes, right? We're going straight there. We're not going to waste our time with supplemental enzymes yet until we get prescriptions in place. And then looking at history to kind of back that up as well. If we do have some carb malabsorption and it's just disaccharides, we might utilize some enzyme supplementation specific to the disaccharides that we're targeting. So if we see fructose, well, fructose not necessarily, but lactose, right? If we see sucrase isomaltase, like targeted enzyme supplementation, monitoring, as well as diet modification, maybe only diet modification. It's important to get the patient's preference on this. And then if we see a FODMAP malabsorption and kind of more of a broader scope, maybe something like a FODzyme, the combination of different enzymes and or diet modification. In my practice, I do both more often than not. Personalized diet as minimal as possible. But again, I follow the patient based on what they want, they need, what else we're targeting. I find enzymes before diet are usually helpful if there's a lot of fear around foods, ARFID in place, like a lot of diet stuff that we're working through, or in patients who, which I see a lot of, are trying to gain weight or trying to support other things in their life, like pregnancy, or like my older individuals that are recovering from injury and we're really trying to put on muscle mass and really prioritize like getting food in. I may utilize enzymes before diet intervention. Whereas another patient, I may utilize diet intervention first and then kind of confirm or sort of test tolerance with enzyme therapy. There's a lot of ways you can do that to really personalize your care. Now, just for kind of general bloating, if it's slow motility related, obviously we're going to treat constipation, utilize diet modification, but there also might be some value to ginger with meals. I actually find this really helpful in practice, even if the evidence doesn't necessarily back it up that much. I find it can help in practice as long as constipation is also being treated. I don't find that ginger alone treats constipation. Now, some of the products that are out there that I utilize, I like motility activator. There's one called Modal Pro. Modal Pro can't be used with certain like psychiatric medications like antidepressants and things like that. So be mindful about some of the ingredients usually added in with ginger in some of these kind of pro motility supplements. But I may utilize maybe one of these products at different doses with some of the meals. Again, where are we dealing with that sluggishness of the gut? Usually this is going to be afternoon and evening compared to like the morning meal, just depending on their routines, what else is going on, symptoms that they're presenting with. If we're seeing results with ginger alone, I may keep that going and then slowly taper it down as, again, the constipation diet modification piece is in play. And we're working on diet fiber intake, all of that. Monitoring labs as we're utilizing the supplement over time and ideally keeping it short. And then if we're not seeing as many good results, with that alone or seeing some results, then I may implement a ginger and peppermint combo. I tend to utilize the ginger I was already using and add in like an IV guard. But you could also utilize a combo that already exists with like menthol added on. That can be an option. Now, if there's diet-related bloating, usually we're going to do diet modification, which can include chewing, all that stuff. Again, we're not mentioning it, but that's where we're going to focus most of our attention. But then also utilizing enzymes and or peppermint oil, as we mentioned with pain, that can be really beneficial. So this is typically what I do in practice. I don't use a lot of different products, but if I am using them, this is kind of how it looks. All right, so now targeting bowel movement. So getting into the diarrhea and constipation of it all, this is where fiber supplements really come into play. So a good little reminder about the role of fiber and what it's doing. We're not only impacting stool form and gut motility, as we're mostly going to talk about today, but there's also room to utilize prebiotic fibers to feed beneficial gut microbes and impact the gut environment. Also, with those prebiotics, increase short-chain fatty acid production, which can impact gut health, gut barrier function, overall health, right? So fiber supplementation can play a role in patient care beyond just bowel movements. But with our IBS patients, that is what we are going to target a little bit more strongly. So when we're considering different fibers, we have changes in solubility, fermentability, and viscosity. And these characteristics are important to know, especially with supplements. With food, food is complex. And most foods contain different types of fibers that have different characteristics. So with food, it's not so simple to say, oh, this is just a soluble fiber, or this is only a viscous fiber, right? It just doesn't work that way. With supplements, these are isolated typically from food sources, and the characteristics can be a little bit more isolated. So we can be a little bit more prescriptive with our fiber, utilizing the fiber as a strategy to have the result we're looking for. And that's what I want you to think about with fiber. It's not so much about increasing just their dietary fiber or some of those other things we mentioned that you can do with food first. You can also target bowel movements food first, but this is a way to really be strategic when you're working with a patient to try to get an outcome. And then you can take what you learned from fiber supplementation and then put that into practice with your diet. So I find it can work both ways, where I go diet first, fiber as a true supplement, or just kind of a now another strategy, kind of second line. Sometimes I utilize fiber more first line, and then I take that information and apply that to the diet in terms of the amount of fiber that they may tolerate, the types of fiber that work really well for them, how fiber is impacting their bowel movements, whatever it may be. So lots of ways to think about it. Now, soluble fibers dissolve in water, insoluble fibers do not. So soluble fibers are great at forming stool, softening stool. Insoluble fibers are great at roughage, so they can help add some bulk to stool. They might be bulking and also create some friction to kind of stimulate movement. Fermentable fibers are gas producing. Non-fermentable fibers are not. You can still have prebiotic fibers that are non-fermentable, which are some of the ones that we're going to talk about. So that's what I like to prioritize. If we can use a prebiotic fiber that's going to feed beneficial microbes, that's non-fermentable and has some of these other characteristics I'm looking for, that's an extra benefit. So that's what I would utilize. And then viscous fibers create more of a gel. So they're kind of like the more thickening gel forming fibers versus a non-viscous fiber. It's just going to mix cleanly. It's not going to be as gel forming. So if we want a lot of like form and bulk, viscous fibers can be really beneficial. So when we're thinking about hypermobility, not mobility, motility, hypermotility. So if we're dealing with diarrhea, loose stools, and we want to improve stool form, generally we're going for non-fermentable, soluble, and viscous fibers. If we want to help improve gut motility and improve bowel movement urgency for those with constipation, we may go for non-fermentable, soluble fibers with some insolubility, either viscous or not, typically even non-viscous, to help improve that motility generally. So like I mentioned, supplements are going to offer more isolated fibers, so you can be strategic with this. And then again, you can take food first or supplement first. There's a lot of ways to do this. Now, in my opinion, the goal with fiber is to normalize bowel movements, reduce symptoms related to bowel movements, and improve the microbial environment in IBS, which can then have lasting impacts. I find that really targeting bowel movements first helps a lot when we get into pain and bloating and gas production. Bowel movements are usually my first approach unless some other symptom just needs a top priority based on patient preference and patient need. And so fiber tends to come up first in some of my interventions. So what are some of the fibers that we have available that I use, but also have some research? Psyllium is the most researched, most utilized fiber supplement that is out there. This psyllium husk is non-fermentable, viscous, soluble fiber. It is really great at being viscous, right? It absorbs fluid, it swells, it creates that gel-like consistency to stool. And this can help with bowel regularity, both for diarrhea and constipation, can really help with stool form. There are a lot of randomized control trials out there. Not patient number, I mean, it's okay for that many studies, but using up to 10 grams per day compared to a placebo or a low fiber diet. So this is used sometimes in diet studies. They found improved global symptoms with supplementation. And some patients may improve with even higher doses. So the higher dose intakes of up to even 20 grams per day. There's not a lot of research on this, but there are some kind of experts in this area and even researchers that have had success doing this more anecdotally. I've had one patient in my practice who was a researcher himself, and he decided to take it on himself to supplement 20 grams of psyllium per day because we saw some improvement. And this is with constipation and poor emptying, which you wouldn't expect really high doses of supplemental fiber to help with. And he saw fantastic results. So that's my only anecdotal experience with this. I'm very hesitant to go up to this dose with some patients, but it can be done. And if you do that in practice, especially if you work with more diarrhea patients, loose stool patients, like please put that in the chat and share your experience as well. Dosing of this is typically going to be around 7 to 9 grams and about 8 ounces of water with adequate water intake throughout the day. And some people will let it mix it together and let it fully kind of thicken a bit and then take it. Usually you're going to drink it before it thickens. I've had patients also kind of do their own formulation here where they add extra water and create what they call kind of a sludge, either extra water or even less water, just depending on the patient. And they seem to see different results. So there's probably some personalization and creativity to use here, just not necessarily something we have in research to kind of back up of exactly how to do that. It's just more patient focused. Another fiber that's commonly used, this is one of my favorites, so just to disclose that properly, partially hydrolyzed guar gum. This is a non-fermentable soluble fiber that absorbs fluid without as much swelling, so it's non-viscous, and it really helps soften stool without as much bulk. So it can help with bowel regularity, again, both for diarrhea and constipation, also helps with softer stools. I find that this helps with constipation more in my practice, honestly. I've seen it can be recommended for diarrhea as well. It still is a soluble fiber, but this is just what I found to be helpful. There was a 2014 study that looked at 5 milligrams over 4 weeks in chronic constipation adults, so not IBS. And they did find accelerated colonic transit time just with that smaller dose. So not super high. A regular dose is closer to 7 grams or 7 grams. So not milligrams, that should be grams. Then there was a 2002 study that did look at IBS patients specifically, over 100, and they compared 5 grams to 30 grams. So 5 grams of partially hydrolyzed guar gum to 30 grams of wheat bran, which is used in some of the older research looking at a high fiber diet. So they were trying to mimic a high fiber diet with wheat bran. And over 4 weeks, they found improved pain and bowel habits with the partially hydrolyzed guar group, as well as the wheat bran group. So just increasing fiber overall. But the partially hydrolyzed guar gum was preferred by participants, and many actually switched from the brand to this group. It does dissolve cleanly in water. It's less fiber overall. That's probably why, but interesting results. It's an old study, but it's interesting to see. There's also a study, this one that is from 2016, that looked at IBS patients at 6 grams versus a placebo for 12 weeks. They found improved bloating and gases compared to placebo, which continued even after their treatment ended for 4 weeks at that follow-up. Not a difference in pain frequency, total symptom severity. So not targeting IBS across the board, but helping with bloating and gases, which might be related to kind of motility potentially, even if stool frequency didn't change. Now, a problem here is that they didn't isolate constipation or diarrhea results, and they did work with all types of IBS. And so could there have been some benefit in the constipation group or the diarrhea group? And then that kind of even itself out where there wasn't overall frequency change? We don't know, but there were no side effects, so tolerated well. The brand that I use here the most is Sun Fiber. That's one I find on the market that is in also other products. So Sun Fiber has its own, but they're usually added to a lot of different products. If you have a brand that you have found that's a partially hydrolyzed guar gum that you love, you can add that in and share it. This does mix into cold or hot liquids, and then it can be mixed into certain foods. Again, dosing 6 to 9 grams. I start with 3 grams for 2 to 3 days, even up to a week, increase from there. And then this can be used any time of the day. I find anecdotally evening is better for bowel movement urgency. Now, what about acacia? I find patients love acacia. I never really recommend acacia, but I'll have patients who use it. This is a soluble fiber. It's from the sap of the acacia trees. It's slightly viscous, so it's kind of in the middle a little bit. So it's maybe be tolerated a bit better than psyllium. It mixes a little bit more cleanly than psyllium, but it can have some bulking, so maybe a little bit more bulking than partially hydrolyzed guar gum. It is considered more fermentable, but usually this is going to be dosed pretty low, and it's still considered low FODMAP. So it's a little bit more fermentable, but again, kind of in that middle ground, not necessarily problematic, and usually tolerated really well by patients. I'll add this study here looking at IBS-C, and they did find that there was some benefit, but they also looked at this versus like a probiotic. So interesting. And then looking at some other supplements that are commonly out there and recommended, there are GOS-FOS supplements, very much more prebiotic, kind of gut health type of supplements. Usually this is added to other products, but these are also FODMAPs that are found in prebiotic foods. Inulin is an example of a FOS. There are some studies in IBS, and what they found is there's no benefit to supplementation for global symptoms. Other studies actually showed a negative impact, which we can imagine is due likely to the fermentability, the FODMAP activity. These are also at higher doses, so could smaller doses be beneficial? I think an example of this would be like some of those prebiotic sodas, right? One of them that came out at one point had like really high doses of inulin added, and people were really gassy and bloated and having issues. I think they decreased their amount, and then it was better tolerated. Might be true even of IBS, but this is not something I would recommend for those with IBS, unless we're very far along and we're really trying to improve, like maybe tolerance to these foods or really impact like the gut environment. Really though, looking at newer research, I think this is something to look at in the future, is that there's some talk about more in animal studies and kind of isolated, so not in human research yet, but in some context, supplementation might be doing more harm than good when it comes to some fibers, and especially some of these prebiotics. There may actually be better benefit to the fibers themselves in the context of food, where sort of where they belong with the other components of food and diet, versus isolated supplementation. And really high doses of some of these types of fibers may actually not work for the body. So just something to look in the future and kind of keep an eye out on research, especially if we can get some human data in that and just a better understanding of fiber isolated versus fiber in food. I did include a little chart of other things that are out there: wheat bran, wheat dextrin, methylcellulose, banana flakes, calcium carbophil. These are some that are in some common brands that are out there that are recommended, and just some results that you can look at here. I will just note banana flakes. This is a resistant starch, very viscous and soluble. This can help a lot with incontinence, and there's some data on incontinence for that. And that will go into my algorithm and like what I'm using, especially for someone with like really intense diarrhea. With that note, we have loperamide or Imodium, and this can help work specifically in the intestinal wall. And then I'm not going to read all these off, but may help reduce diarrhea through these different mechanisms. There is a little bit of data out there, but the bottom line is that loperamide can help with bowel movement frequency. So it can reduce bowel movement episodes, how much people are going, but not necessarily target pain. So most of the practice guidelines do not recommend loperamide. They recommend medications that target both bowel movement frequency and pain. However, this is often used because it is a lower price, and then there's usually more patient acceptance to Imodium compared to different medications. So it's just something to be mindful about. I would say as a dietitian, really be mindful about patients who are preventatively dosing this because they may be causing constipation. And some of these patients aren't ruled out for overflow diarrhea. And so there can be some issues there. Now, on our constipation side, what about laxatives? So we have our osmotic agents, which draw water into the lumen of the intestines. That water coming in softens stool, increases bowel movement frequency by accelerating bowel transit. There are a bunch of different ones that are out there. One that's often used is polyethylene glycol, PEG, also in Miralax. I think Microgol is the brand that's in Canada. This has been used in some randomized controlled trials, improving symptoms, but not necessarily pain. So like loperamide for IBS-D, right? We can increase bowel movements, but pain is not necessarily targeted compared to like medications. And then looking at chronic idiopathic constipation where pain is not a marker, there is more efficacy in overall treatment because we're not trying to target pain, even compared to lactulose, which is a pretty intense laxative. This can be used short-term or long-term. It's very safe. The body doesn't absorb this at all. It's just pulling water in, which is how it pulls water in. And you can dose this with a patient. I find that you can actually utilize this short-term with a patient where you're utilizing other strategies. I typically go with a half dose, work up to a full dose, and then slowly taper down. I've had patients even taper 25% of like a cap at a time and find a lot of benefit in that over a few months, going up and then coming back down. But it just depends on the patient preference of what they want, other factors that are going on. But this can work. I will say it can take about 24 to 48 hours for improvement if you're starting it. Now, beyond that, we also have magnesium. So some forms of magnesium are less bioavailable, less absorbed in the small intestine. They lead to that osmotic effect in the colon. Oxide and citrate are the forms that are most used clinically that have this effect. There are very few IBS specific studies. So these can work. I use these more often. I find patients accept this and use this more often than even like a Miralax, or if Miralax was too intense, some patients will say they may be more open to magnesium. You can dose it a little bit differently. Now, AGA recommends magnesium oxide 400 to 600 milligrams per day to start, with increasing pretty high. Now, with really high doses of magnesium, we have to be mindful about the kidneys. So just be mindful about that with a patient. I find that citrate is actually more gentle. I recommend citrate first before I go to oxide. And I typically will stop supplementation at like 800, 900 milligrams max. I find that when you're getting into that 1000 plus range, patients are having a lot of symptoms related to kind of hyperactivity. So more bloating, very loose, watery stools, more discomfort. Again, we're not targeting pain. So I find that there can be too much of a good thing. And sometimes I find that doctors are dosing like even 1 to 2 grams per day of magnesium oxide, which I find to be a little bit more intensive. Every patient is different, so you can play around with the different forms. But that's where you may utilize some fibers, dietary interventions, other strategies in addition to your laxative to really make the most out of it. Lactulose, I'm not going to go over this, not really studied in IBS, not something that we use, but it's out there. And then there are stimulants as well. So these are going to actually stimulate enteric nerves and promote contractions of GI muscles to kind of stimulate muscle activity. So most of the evidence is going to come from our chronic constipation studies, not a lot in IBS-C. Now, this can work to increase bowel movements, but also will often cause cramping, urgency, diarrhea. For those with IBS and hypersensitivity, this can be problematic. So this, again, isn't used very often. There are some doses here that are used short-term for AGA recommendations. So I added those there for you. Now, what about dependency? Because I think this is an area that is being highly debated, and one I think we all want to keep our eye on, because I've seen low-dose senna used more frequently in practice by GI doctors. And there's a little bit more of an acceptance of low-dose senna chronically, especially in our hypermobility patients, like Ehlers-Danlos syndrome, or patients who are going to have slow motility no matter what. Then senna sometimes can work really, really well, and low doses might be safe long-term. We really need some evidence in this, because high doses of stimulant laxatives over time can create dependence and kind of shut down the bowels a little bit and create a negative problem. But what is that amount that creates that issue? We need to really determine what that is. Patients shouldn't fear these completely. They can be used really successfully in practice. So this is what it typically looks like for me. And I know we're gearing up for our questions. So with IBS, if we have constipation, if I have a patient that's having poor emptying, harder stools, again, I'm not taking diet into account, my referrals to pelvic floor physical therapy, my movement, my hydration recommendations. It's all built in here, right? So we're kind of ignoring that right now. But I might utilize magnesium citrate, typically 300 to 600 milligrams. Once stools are softer, I may intervene with some sun fiber, partially hydrolyzed guar gum, or dietary fiber intervention. Now, if someone is full of stool or has very low output, so they're really true constipation, full of poop, we need to get it cleared out, I'll work with the doctor to clear it out. So typically a Miralax regimen, sort of like a colonoscopy prep, again, working specifically with the doctor to determine that with the patient. You may do these clear outs more frequently in some of these patients. Again, working with the doctor, personalizing, putting a plan together. But then I'll implement, after the bowels have been cleared, 300 to 750 milligrams magnesium citrate first, plus maybe some sun fiber built in over time, maybe trial oxide in this form, maybe continue Miralax, depending on the patient preference. And then usually I will use Senna as needed or on a clearing regimen. So I may even utilize a dose of Senna once a week with the patient if we're really trying to like increase fiber intake, but we want to prevent them being full of stool over and over and over again. Very much needs to be personalized with the patient. But that's a place where you can utilize a stimulant where maybe it's once a week for a month, and then you drop down to once every other week for a month, and then once a month, and then it's as needed. That's something that I've done in practice successfully. Then for my diarrhea patients, if you have incontinence, pelvic floor PT, and then Banatrol, which is banana flakes, I find that to be really helpful, and there's some good data there, so it's something that you can utilize. Now, if we're dealing with loose stools, psyllium husk, increase slowly, go slow with it, can be really helpful. Also, obviously, our dietary modifications I couldn't take out of there. Now, with high frequency, so not just loose stool, but they're having a lot of bowel movements per day, I might work with the doctor on loperamide dosing and loperamide as an option to be able to implement other strategies, and then slowly taper down the loperamide as we increase our dietary modifications and utilize something like a psyllium. Or I might go to like a Banatrol or something a little bit more intensive as a fiber supplement. So I don't think we have time for all these general supplements, but I did include some more here for you if you are interested. Melatonin is used, L-glutamine I know is a big one. There is some decent research. It's pretty low, but 15 grams of L-glutamine for about 6 to 8 weeks has been shown to be effective, and possibly even in addition to a low FODMAP diet. We need more studies in this area, exactly why this is beneficial and why this can help. I find this does help primarily in those post-infectious IBS patients, maybe even in IBS-D or SIBO patients. We don't have a recommendation from AGA or ACG on L-glutamine use, but a lot of dietitians use this in practice. And typically, again, that is going to be about 15 grams if we're going on the data we do have, split into 3 5-gram doses within a day. I typically give it a full like month to 3 months to truly test this. So it can be tricky to implement with the patient. I like the Pure Encapsulations brand because they dose, it's like dosed at that 5 grams. It's a powder form, easy to implement, but may not be safe in those with liver and kidney disease. So screening prior is really important, as well as just being mindful of some other contraindications, which we'll have on your slides. And then probiotics, there's a lot of debates on why they might help. You can read through this. In terms of actual research, there is a little bit of research showing certain strains may be helpful, certain combinations may be helpful, but at the end of the day, there's not a lot of high quality, replicated, consistent research out there. And that's the biggest problem when it comes to probiotics. Probiotics are typically safe in this population with IBS. So they can be used. I do use them. I would say they come way down on my intervention algorithm. Very much a last line type of thing that I would use because I believe the evidence is too weak for a broader first line recommendation. But there is some evidence out there, so you can follow the little bit of evidence we do have to help find a recommendation for a patient, trial a few options with it if they really want to. This website was developed by a registered dietitian, Bailey Hanna, and it kind of breaks down in a little bit more of a user-friendly way the research that's out there. It's called ibsprobiotics.org. So I put this here just because I find this to be a really helpful database and tool that you can use in practice. And patients might be looking for this as an option. So you can even send them this way, thankfully developed by a fellow dietitian. Now, what about berberine and oregano? So the thoughts with these different herbs is to really target kind of the anti-inflammatory, antimicrobial pathways and leaning into the potential of inflammation and gut permeability and microbial imbalance. Can we target that with different herbs? And so there is some research looking at berberine and IBS-D in functional diarrhea, and they did find some benefit. However, in this study, and it was pretty great, they saw 70 and 80% reduction for IBS-D and then functional dyspepsia, respectively, in symptom scores, 50 to 70% over 30 days. So it improved with more time of use. But anyways, they paired this with melatonin and guar gum. So it's small doses of melatonin, small doses of guar gum, but is it just the berberine? Is it the combination? Hard to know. It's not isolated. There was also a study looking at berberine against rifaximin for SIBO, and they tested it against a rifaximin dose that's not actually used. So they showed comparable results, but it was a poor study overall. But it did show that maybe there's some benefit, and it's considered to be safe up to 6 months of use. But really, we don't have a lot of long-term research to really confirm its safety or what's going on over a prolonged period. It can also interact with different medications, so things to be mindful about. And may be helpful again in those as like in the bacterial overgrowth, intestinal permeability, post-infectious group, maybe used in diarrhea more so than constipation. This is being used a lot in kind of that GLP-1 like weight management space. So just something to be mindful about. Patients may be utilizing this and not know the impact of the gut. But we don't have a lot of info on dosing. This is what's been studied. And kind of what I'll say within the oregano piece as well, if we're using some of these herbs as SIBO treatment, if SIBO is a diagnosed condition, we have diagnosis codes for it now. As a dietitian, should we be treating SIBO, especially alone? I don't know. I don't think so, right? I don't think that that's within our scope. And I think that's where the supplement world gets a little tricky, even though supplements are within our scope. To what degree when we're looking at condition treatment? So we really want to work with the medical team on this. IBS or with oregano oil, there's no IBS trials. There's one study in SIBO I linked here for you that looked at this kind of combination herbal treatment for SIBO. And so it did not isolate oregano oil, but it paired with some of these other supplements, and it was effective. But again, what's the exact dosing? Who is it for? Is it just oregano? What all is going on here? Do we need all of these different herbs? Is there safety long-term? And again, what is within our scope in this specific space? And then looking at vitamin D, this is really interesting. Obviously, if we have vitamin D deficiency, we want to supplement and correct that deficiency and look into that. But supplementation showed some benefit in IBS patients, which I found really interesting. So these are really great articles for you to review on your own. Not something we're going to dig too much into, but I wanted to make sure to include them for you to see. So looking at some of these others, if I have a post-infectious patient and they have confirmed SIBO, maybe there's a use for berberine and oregano oil, really leaning into the treatment team and how we're looking at that as a whole and as a team. So I'm going to lean on the doctor as much as possible there, and patient preference, cost, accessibility. There's a lot to consider there. Now, with post-infectious cases, I may also utilize L-glutamine. And then also in my SIBO cases, sunfiber and S-boulardi is a probiotic that has been looked at in SIBO, safe. So these are things that we might implement alongside SIBO treatment. And then ginger may be utilized, especially if prokinetic prescriptions are not available, to help with that in improved earlier intestinal motility, like small intestine motility, to consider. There's a vitamin D deficiency supplement. If you're hitting a wall with the patient, that's where I might consider something like a melatonin or probiotics. If I'm doing everything, not just supplements, but dietary interventions, and we're really hitting a wall, then I may go to some of these that are kind of a little evidence, a little weak, but maybe there's some benefit, then we might utilize them. Melatonin for diarrhea and pain and cramping, and then probiotics specific to the different symptoms that they may have. All right. It's a lot of information.
That was amazing. Thank you so much, Erin. Such fantastic information. And thank you for emphasizing how much supplements are just part of that larger picture of, what we're thinking about when it comes to diet and all the other lifestyle strategies. So we've got some fantastic questions here. I'll start with just a little mix of different topics and some of the common three themes. We'll maybe run over 5, 10 minutes. Folks who are still out there, thank you for hanging with us. Our first question comes from Doris asking about enzymes. How long is the efficacy? For example, if a patient takes a lactase with a glass of milk and then drinks another glass in an hour later, would the enzyme still be present or would they need to take an additional enzyme?
So we typically believe that 30 minutes is kind of that cutoff. I don't actually know if there's good data to say whether or not that's true. Like Jocelyn may know more about even looking at the Shine model, like with FODzyme, but usually we say about 30 minutes. So one dose per 30 minutes. I get creative with the patient. So I dose as patients go, especially with something that's like a powder or a chewable. Like if someone's going to be eating a lactose, like maybe a little bit of queso with their dinner, and then they're planning on having ice cream after, but they're having small portions. I may say take half of your dose with the queso, half of it with your ice cream. So I get a lot more creative with patients in terms of how we dose it, but generally 30 minutes. If you're eating longer than 30 minutes, you may add another dose, which would be true of any of the enzymes, even looking at pancreatic enzymes.
Great. Yeah, that's kind of the rule of thumb that we also use around here at FODzyme. One other FODMAP enzyme question is I've had trouble dosing with dosing of enzymes for FODMAPs. I'm wondering if you can touch on this.
Yeah, it is tricky because we don't have, it's not like, oh, there's this many grams of FODMAP and you want to add this many grams of your enzyme. We don't do that, like, because that would be almost counterintuitive for a patient. They would probably rather just not eat the food than like have to do calculations every time. Nor is it a perfect science because every person's tolerance of FODMAPs is different. So the first thing I think about is what are we targeting? So if I'm using a FODzyme, I educate patients on what am I targeting? If I'm just using alpha galactosidase, what are we targeting? If we're just using lactase, what are we targeting? So they at least know that they're adding that to the food that they're eating. And then we may test dosing kind of based on meal density. So a meal that they make at home where they add a small amount, and this is very much subjective. This is very unhelpful in some ways, but we may try, okay, a half a dose of the supplement if you're only adding a small amount at home versus a full serving of the supplement whenever you eat out and there's more density to that meal. You're eating a bigger portion size. There might be more of that present. If a patient is really concerned or they know that they are very reactive to something like onions, for example, and they get a dish where maybe the appetizer has onions and their main meal has onions, and it feels like a much larger portion than they've tested before, then I may recommend a dose and a half or 2 full doses. Again, and I try to dose throughout. So with the powder, it's really easy. If you're doing capsules, it gets a little trickier. So you may have to take a capsule 15 minutes later into the middle, take another capsule. You could do it that way. Or if it's a powder, you can kind of sprinkle a little bit, eat a bit, sprinkle a little bit, eat a bit. That's how I typically do it. So again, very much an art more than a true science to that. But I find that that can be really helpful and just kind of playing with the patient and letting patients guide that too, because sometimes patients will be testing that. What you want to avoid though is some patients will kind of there's no harm in overdosing your like your enzymes, but they may be wasting their money. And so really helping patients understand that. And if they're dosing a really large amount of enzymes with their meals and they're not sure what's working or not, you may also take a step back and start testing like actual tolerance of those certain foods. So like testing what lactose tolerance actually looks like, or fructan tolerance, or your FODMAPs, like doing the actual challenges and then kind of helping guide dosing based on that. I find that that can be really helpful because you may find that, oh, a small amount of beans is totally fine. But whenever I get up to about a half cup, that's when it's problematic. That's when we may add the enzyme. So that's where you can personalize.
Great, thank you. Really excellent answer, very thorough. We around this time also were getting some comments as you're asking for people's feedback on what they're seeing with Starchway and other enzymes, and we do have some positive cases here where folks are saying that they've been able to help patients with enzymes like that. In terms of our other questions, we've gotten a few around labs for IBS, particularly when you're talking about slow motility treatment. What are you monitoring there?
Yeah, so the labs looking, I mean, it's just kind of general. So as we're doing like CBC, CMP, oh my gosh, cardiometabolic panel, CMP, we can look at some of our liver enzymes. So that can be one sign that you can look for. So your ALT, your AST, maybe looking at some of the urine labs just to see if there's any elevated markers that are somewhat concerning, specific to like liver and kidney. Usually it's just kind of general monitoring at first. I'm not highly monitoring to like an nth degree. If we need to be doing that, we shouldn't really be utilizing supplements, but working with the doctor, I don't prescribe those myself. I work with the doctor and recommend just another, like more often than not, CBC and urine panel with after like 3 to 6 months of supplement use, depending on how many clients are using. If I have clients who are utilizing like really high dose herbals, like they're treating SIBO herbally, and they want that approach, then I may recommend that 3 month checkup of labs with their doctor just to kind of look for any initial warning signs. And even looking at some of the inflammatory markers, like sometimes that's helpful to see just to make sure that there's not anything that's overly like concerning right away. Bilirubin, can be one that we might look at, maybe in some albumin. Just looking at even comparing like the CBC one to the next to see like, is there anything that's off? It may not just be the supplement, but at least gives us some boundaries to make sure that we're considering.
Great, that's very helpful. Thank you. We have some questions around peppermint oil and forms. One was asking about peppermint drops, like not the capsules, and we've got another one around topical peppermint oil. So I don't know if you've got any experience or thoughts
Yeah,
on either of
so
them.
that won't be the same. That's going to go into the stomach. Same for tea. I think I saw something about tea. Those, not to say that those aren't helpful. They may be really helpful, especially for nausea and like targeting the stomach and maybe even a placebo effect with like the smell and the calming effect there. There might even ginger tea. I recommend ginger tea all the time. Ginger tea is not the same as ginger encapsulated supplementation because it's not going to be dosed at the same to like be targeting the small intestine, but even the stomach. Same is true of like peppermint oil. Now, peppermint oil directly on the tongue, like that gets a little iffy. I think heartburn is going to be your biggest risk there. I would utilize the encapsulated peppermint oil. The chances of that peppermint oil or even peppermint tea getting to the small intestine to have those effects we're looking for are very low. So it wouldn't be the same. Topicals, definitely not. Like your skin, that's not going to go to your gut. So will you see a benefit? Can you enjoy it? Maybe, but is it going to have the same effect? No. That's where making sure you have the encapsulated small intestine released capsule that's going to be the most helpful. And I find peppermint oil first over peppermint leaf, just because more of our research is peppermint oil than the peppermint leaf. And again, peppermint leaf is going to be used in your teas as well. So you may see a difference there.
Great, thank you. And we'll end with one kind of fun one from Geraldine who asks, what is a symptom, herb, supplement, enzyme, or approach that you would like to see more researched?
Oh, I mean, herbals across the board, I think, especially looking at like microbial overgrowth and intestinal permeability, some of these kind of treatment approaches with herbals, I think that there's a lot of potential. But I want to make sure that we understand like what is working where, and again, where's that line of treatment and how do we best utilize those interventions. I think that could open a door for a lot of patients, but I think we need more research into how that can work and then being able to extrapolate that into diet, of implementing more herbs and foods and like these kind of antioxidant rich foods. Maybe there's some benefit there. I think it's really interesting. So that's what I would love to see more research on.
Fantastic. Thank you. Very exciting. So for everyone out there, thank you again for joining. Erin, thank you so much for sharing your expertise with us.